Hello, and once again, welcome to Medicines from Around the World. I'm Sid Katz, your host and moderator. Today, our subject is drugs for AIDS. There's no question that one of the major problems in the 20th century, one of the major problems now and the years ahead, is going to be how to treat AIDS and what the role of drug treatment might be. There has been some progress, but to those who have AIDS and those who know people that do or those at risk, the progress must seem extremely slow. Today we're going to find out why, we're going to find out what's down the road, are there going to be effective treatments, where will they come from, and how. And I'm very pleased to have two guests who I'm sure can really fill us in on what's going on because they're right in the center of the action. We have Dr. Julio Montaner from the St. Paul's Hospital AIDS Clinical Laboratories, and he is the co-founder also of a national HIV clinical trials network. Along with him, Dr. Martin Schechter of the Department of Healthcare and Epidemiology at the University of British Columbia, also a co-founder of the HIV Clinical Trials Network. They're going to tell us about AIDS, they're going to tell us about drug treatments, and also the role that this new network might play in hastening getting us the drugs that we will need. So first of all, we're going to start by learning a bit more about the HIV infection, its occurrence, why it takes so long to develop, etc. So gentlemen, why don't you start by telling us a bit more about the HIV infection itself?
Thank you, Sid. I guess we should start by reviewing a little bit what we know about the virus. AIDS is produced by infection with the human immunodeficiency virus. And in our first slide, you can see a diagram showing you the viral structure. This is a virus that is rather unique. It contains a particle which is called the RNA. Unlike most human cells, this RNA cannot replicate itself, and it needs to infect a human cell to be able to use the machinery in this cell to replicate. We inserted this slide here at the request of Marty Schechter because he thought it was most important that we emphasize to you that although we're talking about a very tiny virus, we are talking also about a problem that is global and really encompasses the whole of the world. Going back then to the life cycle of the virus, this virus, thanks to a particle that it has in its surface, is going to recognize specific receptors in the membrane of some cells that we all contain in our body. Perhaps the most important of these cells is an immune cell, the so-called lymphocyte helper. And that is the cell that is being depicted in your slide that you can see in the screen. The so-called T4 receptor is what the virus will recognize in this cell, and it will allow entry of the virus into the cell. The virus will open itself once it has attached itself to the cell, liberating the RNA particle, which is the particle that contains the information that is needed for a new virus to be created. That RNA, through several processes, evolves into a DNA molecule, which now will enter the nucleus of the cell and basically will stay there forever. So that cell is now infected. And as you can see in the following slide, the cell infected at the top of the slide, it will carry the virus every time that the cell divides. And each one of the daughter cells will now be infected as well. So what happens basically is that once you infected a cell, you have infected basically all of the daughter cells that cell is going to ever have. Not only that, but every time that this cell from the immune system activates itself, it will do so preferentially to produce more virus. And that's why the HIV-infected individual, which may or may not have any symptoms, it's at great risk of evolving in terms of disease by the mere replication of this virus through repeated activation of the immune system.
I would just add that it's very important to appreciate that when the virus has inserted itself into the cell, the DNA of the virus is incorporated right into the DNA of the host cell. So it's not sitting on the outside of the cell where it's easy to get at. It's buried deep inside the nucleus, and it's actually part of the host cell's genetic information. And as Dr. Montaner pointed out, that will be replicated for all of the cells that cell ever produces. That genetic information will always be contained in there. And one of the problems with treatment and finding effective therapies is the fact that this genetic information is incorporated right into the genetic material of the host cell.
In fact, like Dr. Schechter was saying, this virus now belongs to you. It's part of your cell. If you are infected, the very immune system that is supposed to be fighting against the virus, it now contains it. And in the process of replicating, in the process of fighting the virus, is creating more virus. For us, from a therapeutic standpoint, it's equally difficult because there is no way we can attack the virus without attacking other cells that are the normal cells of the infected individual. Going back to the ways in which the virus harms the individual that is infected, this slide summarizes a number of the mechanisms that we know. I don't want to spend any time discussing them specifically, just serves to remind you that it's not just direct infection by the virus that produces breakdown of the immune system, but there are a multiplicity of other factors that is sort of like a chain reaction that the virus starts, and it generates the ultimate dysfunction of the immune system.
Now, in terms of the natural history of HIV disease, we are beginning to understand better what the natural history of this infection looks like. It's been difficult because the virus has not been around for that long, but I think we're beginning to understand a lot better what the course is. And what we believe happens now is that an individual gets infected with the virus. Sometimes that individual may have an acute flu-like illness, something like what we all have when we get the flu, with fever and swollen glands and that kind, and sore throat and possibly a rash. The percent of time that there is this acute illness is variable. Some people will have no early illness at all. They'll simply get this virus in a very silent way. Others may have this so-called flu-like illness. At any rate, that early stage passes, and people tend to enter into a long asymptomatic phase, which means no symptoms whatsoever. The person feels perfectly well. They really have no way of knowing they're infected with this virus. And that period varies from individual to individual, but we believe that it can last for many, many years in some people. And as the immune damage begins to arise in mechanisms that Dr. Montaner mentioned, and as these helper cells begin to be damaged and be lost, and as the helper cell count falls, people tend to develop symptoms later in the illness. And we enter into what's called the symptomatic phase, and that can vary from time to time. That can vary from time to time in different individuals. And eventually, as the immune system gets quite severely damaged, the person becomes susceptible to a number of illnesses and opportunistic infections and certain types of cancer, which we call AIDS. And that can happen an average of 10 to 12 years after the first infection with HIV. And so that's what we're beginning to understand about the natural history of the infection. We think that the period of time is getting longer now because some of the therapies that have become available, which we'll talk about, are lengthening this period of time from infection all the way through to serious illnesses like AIDS.
I guess it would be appropriate to make some comments regarding the infectivity of the virus. You should be reassured that there are very few and limited ways in which the infection can be acquired. We generally summarize them by saying that unprotected sexual intercourse, transfusion or transplant of infected organs, and the infection that can occur from an infected mother to a baby are pretty much the standard ways in which you're going to see this occurring.
And sharing contaminated needles.
Obviously, sharing contaminated needles, it would be a way of reproducing microtransfusions of infected blood, which therefore can lead to the infection. As you can see, infection, therefore, can be readily prevented through education, and that's why we take all the time that we can trying to spread the news, if you want, that this is a readily preventable disease and we shouldn't be seeing any more new cases any longer.
Now, one of the controversies is a very important question: what is the proportion of people who are infected with HIV that will ultimately go on to develop so-called full-blown AIDS? It's a very difficult question to answer because there are only few studies that have gone on long enough where we can get any kind of information about that. This slide is from a study from San Francisco that followed a group of people who were infected with HIV, and you can see that at about 84 months, the percentage that had gone on to develop AIDS at that point in time was about 40%. Now, most people, most experts believe that in the absence of any therapy, that curve will probably continue to rise, and we tend to believe that the overwhelming majority of people who are infected with this virus, if they were untreated, would ultimately have immune damage and eventually develop an illness consistent with AIDS. Now, that's changing now because we are beginning to see therapies. So in the absence of therapy, we believe that that curve will continue to rise. Fortunately, we're actually starting to see that curve beginning to bend a little bit, and we believe that that's as a result of some of the therapies that are available. Now, there's, as Dr. Montaner has mentioned, there is a cell in the body called the T helper cell, or the helper lymphocyte cell, or the CD4 cell. It has many names. And it, we think, is really the key cell to measure the damage that this virus does to the body. And it tends to be the most important marker, we believe, of what's going on in a person's body who's infected with HIV. And this graph, which you probably have difficulty reading, basically shows what happens to the helper cell count in two groups of people with time. And essentially, you could concentrate on the left-hand part of the slide, which is a group of people who were observed right from the beginning when they became infected. And you can see that there is this sort of steady drop of the helper cell with time in people who are infected with this virus. And eventually, when that helper cell count falls below certain critical levels, that person becomes at very, very high risk of falling to one of these opportunistic infections or one of these cancers that we call AIDS. And that's why we're starting to try to develop therapies that don't wait until that end stage, but actually intervene at earlier and earlier stages before that helper cell has fallen to those critical levels. And this is just a slide that shows you the kind of, again, the natural history sort of linked to the fall in the helper cell count. And you can see that at the upper left, the person begins, and the word well is there. This is the early asymptomatic phase. And as time progresses, the helper cell count falls. Of course, no one follows this curve exactly. It varies from person to person. But in general, the pattern is one of progressive fall of the helper cell count and progressive increase in symptoms. And there is a phase that is called AIDS-related complex, or ARC, which is a term which refers to some symptoms like oral thrush and herpes zoster or shingles, which are infections that are not really part of the true definition of AIDS, but are indicative of the fact that things are getting worse and that the person is getting a progressively weaker immune system and is probably approaching the time when AIDS is a very serious risk. And then eventually, as the helper cell count falls into the very, very grave zone, the person is at very high risk of developing one of these manifestations that we call AIDS.
I guess this serves as an introduction to the discussion of therapies. I want to point out that the whole goal, if you want, of our intervention with treatments is to try to defer the onset of disease, postpone the development of AIDS until hopefully one day we can cure it, and hopefully make this curve that you can see goes quite rapidly, sort of a downhill course, to make it as flat as we possibly can.
Now, over the last months and years, has the occurrence of AIDS changed? Is it in fact going down, or is it staying the same, or is it going up? What do we know about that?
Well, actually, we have a slide right here. Now, this slide is a little bit early, but it shows the different provinces in Canada, and it shows the cumulative, the annual incidence rate of AIDS. Now, instead of trying to piece apart all the different provinces, all you need to know is that the blue line at the top is British Columbia. We have always had the highest incidence of AIDS in Canada. And what is happening, we believe, right now is that the annual incidence rate of AIDS in British Columbia and other provinces is probably not increasing as fast as it used to, and in fact may be stable temporarily. And the reason for that, we believe, is the advent of these therapies like AZT and like prophylactic things which prevent AIDS, like pentamidine and Sceptra. And we believe that they are taking people who would have gone on to develop AIDS and at least postponing that or pushing that into the future. And so at least part of this flattening of the AIDS curve is due to these therapies that are changing the natural history.
But what about the HIV infection as well, that you say might lead to AIDS in most instances?
Well, this is a very difficult concept for people to understand. You must appreciate that the AIDS cases that are occurring today represent the HIV infection of 5 to 10 to 15 years ago. And the analogy I like to use is it's like looking at light from a distant star. When you look at a star that's 5 or 10 light years away, you're actually seeing that star not as it is today, but as it was 5 or 10 years ago. And many things could have changed since then. In fact, that star could no longer exist, and yet you would still be seeing it. And so it's very difficult to go by the AIDS cases to tell us what's happening with HIV infection. Now, we believe that HIV infection has undergone remarkable changes in some communities. We believe that the HIV infection rate in the gay community fell dramatically in the middle part of the decade as a result primarily of educational interventions that the gay community really undertook themselves. But at the same time, we believe that there are probably other communities that are at risk of HIV, and the infection rate could very well be rising amongst those populations that are at higher risk, and we're worried about that, and we won't see that for many years to come.
Which populations?
Well, I think the populations that people are particularly worried about are injection drug users, people who share contaminated needles, people, what we call street-associated people, people who are involved with drugs on the street, who are involved with sex on the street, with multiple sexual partners, people who have other sexually transmitted diseases. We now know that other sexually transmitted diseases actually assist HIV in passing from one person to another. So really, wherever you find things like gonorrhea, syphilis, and chlamydia, it's very worrisome that you might find HIV as well. And so we worry about all of those people who are at risk for those infections.
I like to emphasize when Dr. Schechter refers to these high-risk groups, he's doing so from a sort of public health and from an epidemiology standpoint. He, because of his background, tends to look at these numbers sort of with a global perspective. In my office, when I deal with patients who are infected, I deal with a human face of AIDS on a more sort of daily basis, if you want. And I want you to get the message right. What he's saying is that there are particular groups who are at a very high risk, but there is no group that is at no risk. Right. And I think it's important that we realize that AIDS or HIV is in our universities, is in our neighborhoods, and it's in all over the place. And it takes one mistake for somebody to get infected. So it's important that even though the massive campaigns of education or the major effort be targeted to the groups that have very, very high risk, we also identify the fact that this is a problem that affects us all.
Are there any questions at this point from the audience? Yes, sir, please stand up.
You have not mentioned anything about the mental aspect of AIDS or HIV. Is there a possibility that people who have HIV or AIDS are in fact in some cases deliberately spreading the disease? And the other one is, you showed a graph a while ago of the spread of the disease over a period of years, And as long ago as 1958, I'd received information saying that a man had died of a mysterious virus accompanied by an unpleasant skin cancer and mental deterioration. And that was as long ago as the late 50s. This man was a homosexual and had lived in Central Africa for about 20 years. So is there a possibility that maybe that research should go back as far as that to see if there's any possibility of the origins of the disease?
Okay, let me answer those two questions in turn. As for the mental aspects of AIDS, we know that this virus infects the central nervous system. And people with HIV infection can sometimes show the effects of the infection on the central nervous system, and it can show up in psychometric testing and things like that. It's very variable from one person to the next. Some people show much more profound central nervous system involvement, which leads to impairment of their function. Other people, less so. As for whether there are people who, as a result of that, go around deliberately spreading the virus, I think that that would be so unusual that it's really not worth addressing. It would occur with the same frequency in HIV-infected people as craziness occurs in the general population. I mean, there are crazy people going around, you know, serial killers and all kinds of crazy people. And I don't think there's anything particular about HIV infection that makes them more or less likely to do something crazy like that.
I'd like to add to that even though, imagine for a minute that I am crazy, I have HIV, and I want to spread AIDS to this audience. I just can't do it. It takes your cooperation for me to transmit the disease to you. Even if I wanted to splash the audience with blood, the virus is so poor when it comes to infecting through casual contact that really it is, I wouldn't say impossible because we haven't tried, and I wouldn't try it anyways, but really we view that as a very remote possibility. Now, what it could occur is somebody denying the fact that he's infected to a potential sexual partner or something like that. And that is why we continuously try to educate people that casual sex is something that has to be regarded as potentially dangerous. And even in those cases, there are precautions that can and should be taken to prevent the transmission of the disease.
Dr. Schechter, what about the second point?
Yes, that's what I want to come back to. Well, we know that there are cases that appear to be AIDS going back to the late 50s. There's a documented case in St. Louis in 1959. So the case you mentioned comes as no surprise. Nobody believes that this virus completely became new in the late 70s. We believe that it began to spread to a much greater extent in the late 1970s and early 80s, but we believe the virus has been around for at least a few decades, and we believe it remained very, very localized until it began to spread. So these early cases come as no surprise.
Okay, I think perhaps we should get on at this stage to the drug treatment itself. What do we have available now? What are we going towards? So perhaps we can address that question, then we'll talk a bit more about these issues.
I guess the central agent that we have at this time for the treatment of HIV infection is the so-called ACT, Retrovir, Cidovudine, etc. It's known with several different names. You have on the screen the chemical sort of formulation of this compound. This basically, you can think of it as a false brick that the virus is going to use. We are going to fool the virus to use this false brick to build up the new virus, and therefore is going to be unable to continue the process, and therefore the new viral particle is going to be incomplete and unfertile, if you want. There are many other actions that this compound has. We must recognize that this compound will also be taken by normal cells of the bone marrow and other places in the body. And these cells are going to also be confused and also going to suffer the effects of this treatment. ACT, as we call it in daily use, it only affects the virus in a reversible fashion. That is to say that it comes, it attaches in certain place, but this is a reversible binding, and therefore it can come apart and the new and the real brick can come over, and therefore viral replication can continue. And that is why ACT cannot cure the disease, it can only slow it down. The initial and I guess definitive proof that ACT was effective in the treatment of this condition came from a study that was performed in the United States by a group of researchers. The leader of the group was Margaret Fisher in Miami. And in 1986, they basically treated a group of patients with ACT, patients with AIDS and with ARC, with advanced disease. They gave them ACT to half of them and no treatment to the other half. And that at the time was felt to be reasonable because there was no treatment for HIV. And this was, although potentially useful, there were a lot of concerns with regards to its toxicity. Thanks to some statistical manipulations of the data, very rapidly the study was completed. In fact, about half of the group of the patients that was studied only completed 8 weeks in treatment. And by that time, there were 19 deaths in the group that received no treatment, while only 1 death occurred in the treated group. And this led to the discontinuation of the study and to ACT becoming available for the treatment of people with AIDS and ARC. At the same time, opportunistic infections, which are the unusual infections that we see in patients with AIDS, were decreased by half in patients treated with ACT. And there were a whole lot of other beneficial effects that were identified. The problem was that at the doses that we were using ACT those days, we were finding a lot of toxicity. And this is just a slide to remind me to mention to you the fact that the price we pay from using ACT at those doses was relatively high. Most people had either side effects, subjective side effects, or problems with the bone marrow, right? Either anemia, which is a drop in your red blood cells, or leukopenia, which is a drop in your white blood cells, etc. Fortunately, most of these was relatively mild and fairly well tolerated, and when we stopped the drug, in the cases that we had to, the side effects tended to disappear. The anemia, for example, we now know is not only a function of the treatment with ACT, but it's also a function of the advancement of the disease. And in this graphic, you can see that very few patients develop anemia when they are HIV infected and asymptomatic, even though we're treating them with ACT. Very few patients, if they have mild symptoms, like symptoms of ARC, but when they have full-blown AIDS, the development of anemia is rather a characteristic finding. Many more trials follow these studies, and I don't think it's worth it that we spend a great deal of time discussing each one of them. The point is that in February 1990, the FDA, the Food and Drug Administration, and later on the Health Protection Branch in Canada, extended the license for ACT use to all patients with CD4 counts or helper counts below 500. And I want to put this into perspective for you because I think it's rather important. The normal helper count that a non-HIV infected individual would have is somewhere in the neighborhood of 400, 430 to about 1,200, 1,300. So it is the first time then that we were now able to treat patients who are asymptomatic, HIV infected, even though the laboratory parameters could be basically completely normal. This created a great deal of concern and controversy because patients like that, they could remain healthy for 5, 6, 7, 10 years before they develop AIDS. And to tell somebody that you're going to treat them with a drug that is potentially toxic like ACT on the basis of the available evidence when the patients are completely healthy otherwise is a bit of a problem. Further fuel to this controversy was given by the fact that the studies that were performed in the States were terminated quite early I guess as a product of the anxiety that we all have to find new and better tools to treat these patients. And at that time, when the data was sort of reviewed, it became apparent that although the progression to AIDS was favorably affected, we were paying a price in terms of adverse effects. And when we balance both things, the net effect was not quite as clear, particularly because patients that progressed did show evidence of progression, subtle evidence of progression prior to the development of full-blown AIDS. It is for that reason that in an editorial that we wrote with Marty Schechter, John Rudy, and myself, some time ago, we concluded that the treatment with ACT of patients with helper counts between 200 and 500 who had no symptoms, it should be cautiously endorsed at this time, and particularly it should be promoted among patients who have mild symptoms or other subtle evidence of progression of the disease.
Now, I guess one of the questions we can ask at this stage is, why has it taken so long to get to this point, to come up with AZT? Once we had it, we had to determine that it was useful, but why did it take so long to get to that point?
Well, I guess there are many aspects to that question. From a research standpoint, from an academic standpoint, if you want, the major difficulty with this disease is that we had no prior experience. We didn't know what was producing the disease. It took a considerable amount of time to figure it out, to isolate the virus. In fact, still today, there are very prominent researchers that view the concept of HIV being the cause of AIDS or the single cause of AIDS as slightly controversial. We personally don't adhere to that view, but still there is a certain degree of controversy regarding that. You have to remember that when it comes to viral diseases, we have never been successful. In fact, there are only 1 or 2 viruses out there that we have been able to get therapies for. For the most part, either we did it with vaccines in the past, or we have been not able to do anything at all for the viral diseases. Vaccines are at this time not a prospect or an immediate prospect for HIV, and besides, it would not be a treatment anyways as a vaccine is usually used because we're talking about people that are already infected. The next step is that we are now starting to see more compounds that we potentially can use, but this is creating millions of potential combinations, and really we don't even know if the winning combination is out there. We suspect that the winning combination is not there. In fact, what we have is ways in which we can advance the treatment and continue our progress, if you want, in the sense of trying to transform this into a more chronic and manageable disease. Mario?
I was just going to add, time can be measured in many different ways. And, to put some perspective on it, if you realize that this, first of all, the epidemic didn't really begin in earnest and wasn't recognized until 1981. We thought this was a virus, but the virus was not really identified till 1983, 1984. Antibody tests to determine if a person was infected with this virus really weren't available until 1985. And then by the year 1986, we already had the first agent that showed success at treating or delaying death in people who had full-blown AIDS. And this for a virus that we've never had to deal with before, a retrovirus. And as Dr. Montaner points out, we have very few drugs that deal even with garden variety viruses. So if you adopt that perspective, I think the achievement's quite remarkable. Now, at the very same time, for people who have HIV infection and AIDS, all of us understand that that's not good enough. So that's how time can look from 2 different perspectives. Everybody's trying as hard as they can, and no matter what we do, it's not going to be good enough as long as there are people out there with AIDS who are facing deterioration.
Well, now that leads us to the future. The HIV Clinical Trials Network, you're co-founders of that. How is that going to help finding drugs, and what are the trials that are going on now or might be going on in the next few months?
Well, let's address the network first, and then we can tell you a little bit about the trials. But we have been involved in clinical trials for AIDS for many years now, and we've been frustrated by the fact that it has been very difficult for us to bring new compounds into testing, to set up the structures that are needed to create a positive environment so that the drugs that are out there and the companies that have the drugs would be tempted to say, okay, Canada is a favorable ground, is a fertile ground for us to bring these medications and see whether they work or not. And basically what we did is we got together, and that's not a novel idea, but certainly what we did is we applied concepts that other people had applied to other diseases, and we created, or at least proposed, to create a basic infrastructure that would be ready to go all set and just waiting for things to happen. It would not be like in '87 when we first were given the opportunity to work with ACT that we had to go and get organized. Or like later on with aerosol pentamidine that we had to go and get the whole thing moving and starting from scratch. We now, and I'm happy to report to you, we now have an infrastructure that we can go and actually go out and compete for these drugs and say, ladies, gentlemen, bring your drugs, we're ready to go, we have everything that is needed. And in fact, people are starting to look at us and say, well, you know, these people are serious about it. They have everything it requires to do these trials. And I'm sure that if you're not yet aware, you will be becoming aware increasingly so in the next few months, in the next several months, that there is much more activity going on in clinical trials in Canada now than ever before in the subject of AIDS.
I would just add that we, in putting this network together, if you really, people think about the logistical problems of trying to put together a multi-center clinical trial, they're enormous. You have to identify people in different parts of the country, you have to identify the staff, there's all this hiring problems, there's all this red tape. It really is an enormous problem, and to keep doing it over and over again when every new therapy comes along, it's reinventing the wheel, and it just creates intolerable delays. And so the principle of the network, as Dr. Montaner points out, is to get rid of all that red tape, to have an infrastructure in place, and quite frankly, we want to make Canada an attractive place for people to bring promising new drugs, because we want Canadians to get a chance at having them first. If we don't have this kind of network in Canada, then I can assure you the best AIDS drugs are going to be evaluated in Europe and Japan and France and the United States, and not in Canada. And so the principle of the network is there's quite a selfish motive from the Canadian point of view. We want to make Canada an attractive place and get the best therapies being tested here.
So what are the drugs that are now being tested, and are they an advantage over AZT?
Well, the first part of your question is yes, we have several drugs that we're testing, and I'll walk with you through one of them, DDI, which is one of the agents that we are currently testing in the Canadian Trials Network. The second question is going to remain unanswered, and I apologize for that, but if I knew the answer, we wouldn't be doing the testing. And so truly what we're trying to establish is where does DDI fit in comparison to ACT? Is the same, better, or worse? Should we be looking at mixing these drugs, alternating these drugs, etc.? But briefly, what I can tell you is that DDI, dideoxyinosine, is to some extent similar to ACT in the ways it works, and therefore we won't spend too much time on that. In this slide, I show you the summary of the phase 1 data, which is the early experimental data that demonstrates that as far as the bone marrow is concerned, which is an area that ACT is very toxic, DDI is not. And as you can see, if you scan the slide briefly, you see most of the lines are rather flat, and you don't see the dips that you would see with ACT. And here we show you two particularly important markers. We call them surrogate markers of viral disease or HIV disease activity. One goes up, and the one that is going up is the CD4 count, the helper count. And as Dr. Schechter already discussed earlier, this is a key parameter in the natural history of the disease. So make this, if you can make the CD4 going up, that means that the drug is in business. And not only that, but the other line that you see with a gentle decline is a line that measures viral activity in a different way, is the so-called P24 antigen. And the more you have, of that, it is felt that the more activity of the virus you have. And what you can see here is with treatment, that tends to go down. Now that's by no extent of the imagination, that is not the answer to the problem. We had to recognize that this drug, even though at this very early stage, has a number of toxicities, and we list some of them there, the pancreatitis, which is an inflammation of the pancreas, the peripheral neuropathy, which is the numbness and tingling of the feet and arms, hepatitis, or inflammation of the liver, cardiac rhythm disturbances, particularly in people with cardiac disease, pre-existing cardiac disease, problems with rash, problems with gout, problems with muscle, etc., etc., etc. And basically what we're trying to do, and this is the concept of the study that we're trying to do, is we are currently using DDI at the end of the spectrum. If you follow the story so far, you realize that when we talk about AIDS, the immune function is very low. So in patients who have failed or cannot tolerate ACT and who have very low immune function, we are treating them with DDI because really there is no other resource available to them or to us. For patients that are higher up in the curve, who are not yet going sort of downhill, if you want, we're testing them in a comparative fashion. We're taking people and asking them to help us to try to discriminate whether ACT is actually better than DDI or continued ACT is better than starting a new antiviral, the DDI. The idea being that if you become intolerant or if you deteriorate while you take ACT, hopefully DDI is going to be able to reverse that and bring the patient back to a more stable status. And that's the basis of one of the Canadian trials that we're currently undertaking with DDI.
I would just add that, not to get into the specifics, but there are really two strategies we can adopt for the treatment of AIDS. Now, if you think about AIDS, AIDS is a combination of HIV infection and the progressive immune damage that it causes. And Dr. Montaner has been talking about AZT and DDI. Their mechanism of action is to work on HIV and to prevent this immune damage. At the same time, there are a number of manifestations of AIDS. Though AIDS itself is not HIV. It is the pneumonia that people get when their helper cell count gets too low, called pneumocystis pneumonia. It's also the kind of cancer people get called Kaposi sarcoma. And a whole other type of attack on AIDS is to get better and better ways of treating these manifestations and also trying to prevent them. For example, we mentioned the concept of aerosol pentamidine. That's a method whereby a person can breathe in or inhale this drug on a once biweekly or monthly basis, even before they ever get AIDS, in the hope that this will, by having the drug there, it will prevent the organism from taking hold and causing AIDS. And so the two lines of attack we see in the future are different antiviral therapies that actually work on HIV itself, alone and in combination. And I think combination therapy, using DDI and AZT or DDI and DDC, these drugs alternating or together, is one wave of the future. And the second wave is going to be better and better attempts at controlling and preventing these opportunistic infections.
Right. Dr. Schechter mentioned these complications. Now, Dr. Montaner, I know you've done quite a bit of work on at least one of these complications. Could you perhaps elaborate how important that is, and is this really something that we have to really focus on?
Well, as you know, AIDS was initially discovered, if you want, or we ran into it when we ran into the complications of the disease. And that's why our initial interest was focused on trying to deal with these complications. The most salient complication, if you want, is a pneumonia, which affects the lungs, obviously, and it's called pneumocystis carina pneumonia. On the screen, you have an X-ray, which is a picture of the lungs, which is abnormal. But in case you don't perceive the abnormality there, let me show you another one that is much more abnormal. That is, as you can see, the lungs should be completely black, and in this case, they are almost completely white. And this is a woman that we treated some time ago, many years ago, I must say. She had a resection of a tumor, even many more years before that, for a localized disease that she had. And in the process of that treatment, she received a transfusion, which was infected and led to the development of AIDS. When we did biopsies of her lungs, they look like this. The narrow lines that you see going through the screen, are the normal walls of the lungs. In the center, those rather amorphous material that you can see is the exudate that accompanies this pneumonia. That is the PCP. And that material is replacing where the air should be, and therefore you can basically not breathe. There are three problems with this disease. One is you may die, and that's certainly something that we would like to prevent. The other one is that the response to treatment is very slow, and I'm not going to spend too much time on that. But the third thing is that the relapse rate is very high. So even if you don't die, if we manage to treat the disease, the patients tend to repeat the pneumonia, or the pneumonia tends to come back at a rate of approximately 65% at 18 months. So we, with Dr. Schechter, conducted several studies, one of them using adjunctive therapies to try to improve and accelerate the response to treatment in these patients. And without going into too much detail, what we found is that we could decrease the mortality of this disease from about 90% plus in the very severe cases to under 40%, which was a dramatic improvement. Later on, we were able to demonstrate that we could speed up the recovery of these patients in a very dramatic fashion. And more recently, and I'm showing you the slide on the screen, we were able to show that using aerosol pentamidine, we were able to prevent 85% of the relapses. And here you have the data from a Canadian cooperative study, and in basically the dark circles, or the white circles, I should say, are showing you the rate of recurrence of the pneumocystis pneumonia in patients who receive no preventive therapy. And that can be as high as about 60% in 24 months, while in patients that receive aerosol pentamidine, the relapse rate was under 10%, and this is a very dramatic improvement over what we had before this study was conducted.
Well, we've heard about what's available now, what might be available in the future. The fact that the clinical trials network certainly will enhance the ability to have trials and perhaps new and better drugs. There must be questions from the audience now in terms of what you've heard and some of the new information, maybe clarifications of some of the points that were made. Do we have any questions? I know I've got tons of questions. I'm sure that you might as well. All right. One thing you haven't said anything about has been the vaccine. A vaccine, and how does it fit in? So first of all, where are we in terms of a vaccine? And can we really think of a vaccine as a therapy, as something which we might consider as a drug?
Well, you've raised an interesting point. Vaccines for HIV can be thought of in two ways. The classical use of a vaccine is you give it to someone who is not infected with the virus in the hopes of preventing infection. And that is certainly, from the global point of view, one of the fundamental challenges in HIV is to develop an effective vaccine that will prevent infection. And a lot of work and effort is going into that. There are approximately 6 candidate vaccines right now that have been developed. There is some early laboratory work, especially with using chimpanzees, that suggests that you can, in fact, induce an immune response. One of the problems, of course, is the way this virus gets into the body. It has so many cells that it can get into. You have to promote an immune response that will prevent that. The second challenge is the fact that this virus has many strains and different mutations of HIV, and you need to come up with a vaccine that will protect against all those possibilities. And so that's the challenge on that side. You raise another interesting point, which is the use of a vaccine in a non-traditional way, which is as a therapy itself. And there is some work going on right now which gives a vaccine known as GP160, which is that surface protein that sticks out of the virus, and gives it to people who are already infected with HIV. And the purpose of that, of course, is not to prevent HIV infection, but to boost the body's immune system against the virus itself in the hopes of adding to the therapeutic, adding to the body's ability to control the virus within it. And there is some evidence from early studies that vaccines may play a role as a therapeutic agent in people who are infected. This is all very, very preliminary. We're still talking about phase 1 and phase 2 trials. The difficulties with vaccine research are very enormous, and it's going to be a few years. But I can tell you there are phase 2 trials of vaccines starting right now.
What's a phase 2 trial?
Phase 2 trial is where you're actually going to phase 1 is simply where you give it to a small number of people and test them very carefully to make sure that it can be given safely without killing them, essentially. And the phase 2 trial is where you actually begin to compare the effects in a group against a group of controls to make sure that the vaccine is creating the type of response you want it to. And so those types of trials are beginning right now, and some of them will be in Canada.
Although we are very optimistic about the vaccine trials, I feel obliged to stress the fact that we are aware of potential complications of the use of vaccines, and that's why we have to proceed with some degree of caution before we can endorse this, which appears to be a very exciting new area.
Now, something else you mentioned that we should mention is that there is a National Advisory Committee on AIDS, and Dr. Schechter, you're a member, a new member, of that committee. Now, you're involved in AIDS research and as a co-founder of this network. Put on your other hat as somebody on the National Advisory Committee. Would you advise that we're doing enough? Do you think that we're getting somewhere and that we're doing enough in terms of searching for better treatments?
Well, that's a very difficult question. I think there are a number of ways to look at that. You can compare Canada's effort against AIDS strictly financially by looking at what the government has been prepared to spend on education, prevention, and research, and you can compare that with other countries like Canada. It would be unfair to compare directly, for example, with the United States because their epidemic is larger. Or it would be unfair to compare with Australia, for example, because their epidemic is smaller. But we did an analysis on the National Advisory Committee and found that after you adjust for the size of the epidemic and look at a per capita expenditure, Canada is spending about 40% of the analogous rate of the United States and about 40% of what Australia is spending. And therefore, we are definitely underspending on this problem vis-a-vis other developed countries. Now, some people argue, well, Canada underspends on research and development across the board, so why shouldn't they do that about AIDS? And what can I say? I guess if that's a national epidemic of not taking research, development, and prevention seriously, then we've got a big problem. I think that when you look at research like the Canada Youth and AIDS Survey that tells us that our young people, our high school students are out there, they are having unprotected sexual intercourse. This is not, this is a fact, it's not fiction. We know it's true. You have an option of hiding your head in the sand, or you have an option of actually spending the money to make the education happen, to make the condoms accessible, to do all the things that may be politically unpopular, but from a public health point of view have to be done. So I think the answer to your question is there's a lot more that Canada has to be doing. There are certain things with regard to human rights legislation, with regard to people in prison that we are ignoring. I don't think we have enough needle exchange programs around the country. We did that too little and too late. Fortunately, at least something's happening, and before the horse got out of the barn, we have some programs starting, but there's an awful lot more we could be doing.
Thank you. Questions? Yes. Could you come forward, please?
One of the issues that I'm really interested in getting your opinion on is that you said earlier that you're now advising perhaps one should take real caution in using AZT if you're asymptomatic and you had a low level CD4 count. And given the fact that in many cases you have to meet certain criteria to get drugs and to get into clinical trials and so on, what does the person who, let's say, is infected but doesn't have a low CD4 count, doesn't have any symptoms, what should they do?
They should be happy. The reason why we advise against using ACT is because there are well-controlled trials that have shown that the advantages, if you only look at the bad side of the equation, which is the progression to disease, that the ability of the ACT to prevent that from occurring is there, but it's rather limited. So, you know, you're asking me an unfair question. You're telling me, in the absence of evidence that ACT works, what do you expect me to do? And I'm saying, I don't know. The fact that I don't have any better treatment than the treatment that is not there, it doesn't mean that it's my fault. We're doing our very best. I do understand the position of many patients that they get really anxious about it, and they really look at us saying, but, you know, what are you doing for me? And my answer is, we're doing our best, but we just don't have it. We just didn't come across that agent that is going to truly change the natural course of the disease. This is very disturbing because as of a few days ago, and through the underground, basically, we have learned that a recent study has shown, or at least there is a rumor that the Veteran Administration study, which was a long-term ACT treatment study in asymptomatic individuals, is showing that the short-term gain that the American study, the 019, has shown is only a short-term gain, and ultimately, when it comes to survival, probably the advantage is not there. So this only reassures us that our earlier impressions that early ACT may not be the ultimate answer is probably correct, but that doesn't make us happy. We don't have a better answer. We're actually very sad to conclude that.
You know, I think that this is a very good question. It's the toughest clinical question. Is you have someone with HIV infection, let's say their helper cell count is 600 or 700 or 800. They're not eligible really for these drugs. What should they do? What should you do for them? And I would love to be able to have a non-toxic drug that you could give to someone at that level of helper cells that they could take for years and years, and it would hold them steady. It would be like giving insulin to a diabetic. That's what we're working for. The frustrating thing for a person at that situation is they have a lifespan ahead of them that is very variable. It could be as long as 10 or 15 years. There are people we know I mean, a helper cell count of 700 or 800 is like the helper cell counts of most people in the room. And the potential to do harm with a toxic drug could actually shorten their lifespan rather than lengthening it. And so it's very frustrating to, I would love to have a non-toxic therapy like insulin, and that's what everybody's working towards. It just doesn't look like AZT is going to be the one right now.
Well, you're dealing with a difficult problem because, as you said before, it's one thing if it's a serious infection. It's another thing if it's a serious viral infection. I mean, let's be honest. We have 1 or 2 drugs, as you said before, Dr. Montaner, which are used in different types of viral infections. Colds have been around for centuries, and we still cannot treat the common cold. So it's a serious problem. I think it's probably a good thing that we have this clinical trials network. Hopefully that will lead to new and better drugs through testing. The other thing is that the fact that we have set up a national advisory committee obviously means that we're giving credence to the problem and we're trying to deal with it. There's no question, though, that we're in a situation where a lot of people are suffering and they want results. And I'm sure that you gentlemen feel that pressure. I want to thank you both, of course, for coming here and sharing the information with us. Sometimes in a situation like this, it's hard to get this type of information. And I think that perhaps is the first thing that we can expect, is the information of what's happening right now. So I thank you both, Dr. Julio Montaner, Dr. Martin Schechter, for sharing your views with us and your very good work. Thank you very much. And I know I've learned a great deal, but I'm going to ask some of the people in the audience if they've learned anything. Have you learned anything new today?
Yes, I have. I did have a question, though, I wanted to ask.
Go ahead, ask the question. They're not being paid by the hour.
That's
good.
We should have been.
You mentioned something briefly in the beginning about Septra and one other drug that you were using.
Aerosol pentamidine?
Right. This is what, to treat things like your pneumocystis carnii?
Correct.
Okay,
in
so
people
this is
who have
maintenance
a
then.
more advanced immunodeficiency, even before they ever had any manifestation of the disease, we now know that by giving them this preventive therapy, we avoid them from getting the pneumocystis pneumonia. At least we postpone the pneumonia for a prolonged period of time. So if at all possible, we want to get everybody on treatment with these prophylactic medicines.
Oh, so you are treating with the Septra even though you haven't actually found the pneumocystis?
Correct.
Oh, I see.
We're doing what we call primary prevention.